And this is a very important topic for us clinicians, how to treat patients. And I think your question implies an important or an aspect that will become very important in future. Which first-line therapy do we want to give to a patient, and what do you think is the best sequence? And of course, what is the wish of the patient? So we have to consider different aspects. Is it the patient that really wants to have a time-limited therapy, or is that aspect not so important for the patient? In which country is the patient living? So I don't think that all countries really can treat their patients with all the new fancy drugs in all the lines. So is it a country where chemotherapy was applied in the first line? How long was the response or the progression-free survival of the patient after therapy was finished? I think we really have to consider all that aspects to provide a really good second or third line therapy. I mean, for today, I would say, okay, patient that is on Ibrutinib treatment, and those are most of the patients which gets Ibrutinib in frontline and then relapses. That is a candidate for Venetoclax treatment, right? But in the future, we will have more and more patients that will be treated with Venetoclax in first line, and then the situation is, of course, a different one. And these patients maybe are then good candidates for Ibrutinib. But of course, we also don't know when there's a patient who received Venetoclax in first line and then has a very long progression-free survival, more than over several years. So is it maybe a candidate for retreatment with Venetoclax again? I think these are things and questions that we have to answer in clinical trials by testing really the optimal sequence. And then we, of course, need to give answers how to treat patients being refractory on BTK inhibitors and BCL2 inhibitors. And maybe for the short term now, we have the non-covalent BTK inhibitors that most probably will be efficient in that particular patient population, but we don't know for how long, because obviously these patients are relapsed up onto very highly specific and efficient lines of therapy. So these might be patients that also are at risk, I would say at least at risk for relapse after maybe short treatment with a non-covalent BTK inhibitor. And therefore, I think we still need to improve our cellular therapies, like CAR T cells, the application of bispecific antibodies, and there is still some room in that scenario for allogeneic stem cell transplantation.